Welcome, everyone. Thank you for joining us today. My name is Melissa Begg, and I have the great honor of serving as Dean of Columbia University School of Social Work. We are delighted to welcome today's distinguished scholar, Dr. Victoria Frye, as our guest speaker in the Dean's Lecture Series on Inequality and Opportunity. Through this series, our community has the chance to come together to explore the complex system of racist and oppressive structures and policies that result in inequities, inevitably, and with a particular focus on disparities in economic opportunity, educational outcomes, criminal justice, healthcare access, and overall well-being. I'm really looking forward to today's discussion of interventions for social stigma and intervention, which are aimed at reducing inequities. Now I have the pleasure of introducing our moderator for this event, a superb scholar and a wonderful colleague, Dr. Nabila El-Bassel. Dr. El-Bassel is the Wilma and Albert Musher Professor of Social Work and also University Professor. That is the highest academic honor and rank bestowed upon Columbia University faculty, and in her case, with very good reason. In addition to leading the groundbreaking Healing Communities study, Dr. El-Bassel directs the Social Intervention Group and the Global Health Research Center of Central Asia. Hallmarks of her approach, in my view, I hope you agree, Nabila, is that she always takes approaches that are theory-driven, solution-focused, and deeply community engaged. Under her leadership, the school launched a new university-wide interdisciplinary center to combat the growing crisis of substance use disorders. Chosen, the Center for Healing of Opioid and Other Substance Use Disorders, Enhancing Intervention, Development, and Implementation, draws on the expertise of faculty, researchers, practitioners, cross-sectoral organizations, and community members to develop and implement programs, policies, and practices that treat addiction. Dr. El-Bassel is a member of the Provost Advisory Council for the Enhancement of Faculty Diversity. And beyond Columbia, she serves on numerous boards and committees, including Harvard's Scientific Advisory Board on Migration and Health. Professor El-Bassel's career in social work and health promotion spans many years and transcends disciplines. She's one of the world's leading experts in intervention science. She has published extensively on HIV behavioral prevention science, substance use, gender-based violence, and complex cross-disciplinary interventions. In addition to being a remarkably productive researcher, Dr. El-Bassel is an incredible mentor. Last year, she received the Provost University-wide Faculty Mentoring Award. This is such a well-deserved recognition of Dr. El-Bassel's exceptional capacity for and commitment to mentoring. Nabila, we're so lucky to have you on our Columbia faculty, and I'm going to turn it over to you now for what I know will be a really great session.
Thank you very much, Dean Bagg. I really appreciate your generous introduction. It is really great pleasure and honor to me to introduce Dr. Frye. Dr. Frye is currently a medical professor at the City University of New York School of Medicine, where she teaches on population health. Also, Dr. Frye directs the Laboratory Urban Community Health Center at CUNY University. Dr. Frye studied at Mellman School of Public Health, where she received her master's degree as well as her doctorate in sociomedical sciences. And guess what? Also, Dr. Frye attended Columbia University for her undergrad education. Dr. Frye, it seems like you spend a lot of time at Columbia University. It's really a pleasure to have you today with us and to present at a School of Social Work at Columbia University. As a graduate student, Dr. Frye was trained as a rape crisis counselor and also became a trainer for counselors and worked very closely with victims of rape cases at the Crime Victim Treatment Center. I remember at that time it was called St. Luke's Roosevelt Hospital. In 1999, Dr. Frye served as the director of the Injury Prevention Program at the New York City Department of Health and Mental Hygiene. What she did at her job at the city is to map the scope of intimate partner violence in the city. And I remember very well that your report that was produced by the New York City Department of Health made so much impact on the way we perceive violence against women. I remember at that time I used your work in my research. And in 2004, Dr. Frye worked as a researcher at the New York Academy of Medicine And where she worked there, she also innovated in relation to understanding neighborhood environments such as stigma, social and sexual networks, and how all these environment factors really influence acquisition of HIV and access to treatment. And again, I remember at the time, I really was so excited about your report and informed my work. Dr. Frye has been a principal investigator on numerous NIH-funded research, as well as she has been funded by CDC. Among her work, that really is very exciting, Dr. Frye examined how community neighborhood level characteristics associated with partner violence. And her work is not only studying this link between violence and the social structural issues, but also she takes her work and inform policies and intervention to reduce violence against women. And also Dr. Frye is involved in a number of HIV prevention interventions that have been funded by NIMH. And the most recent one, she's working on prevention studies for Black or African-American population. She's working with gay men, bisexual, same gender loving men who have sex with men. She's currently, in fact, we have two studies on these issues, and these two studies have been funded by the National Institute of Drug Abuse. I have to say, despite that she is so busy with her research, she's also mentoring a large number of junior faculty as well as postdocs at her department and also at the university. At the City College of New York School of Medicine, she leads a really very important committee. It's called the Action Collaborative Initiative on Preventing Sexual Harassment in Higher Education. I went to read about it and really was so excited to see the production and the emphasis of this group. And I really appreciated that focusing on these important issues. She also served as the co-chair of the Faculty Senate on Diversity, Equity, and Inclusion. She serves 2 terms as faculty senator at the City College of New York. And also she currently leading a very interesting and important committee on the impact of the twin pandemics of COVID-19 and police brutality and systemic racism. And she's looking at how these 2 pandemics are interrelated. And in addition to her amazing work, she also appears in New York Times and other media outlets. And I remember too, I read about you in The Spectator, really a great story. You are active in the community, you're active with students, your research is amazing, and I'm really looking forward to your presentation today. So the title of Dr. Frye's presentation is Social Stigma and Discrimination Intervention, Prevention Science to Reduce Social Inequities. I want to stop here and give you the time to tell us about your amazing work. And thank you for taking the time from your so busy schedule.
Thank you so much for that incredibly kind introduction. It's just lovely to be here. I'm honored. Honored to be in the presence of you and many other fantastic researchers, scholars, educators here on the call tonight. So thank you for being here. Yes, so today I'm going to be talking about social stigma and discrimination interventions and how we can use prevention science, hopefully to reduce social inequities. I'll start off with just a little bit about myself, my overarching approach, and then focus in on 2 projects in the HIV prevention research program, the CHANGE study and the CHARGE study, and then talk a little bit about next steps, and then hopefully we'll have lots of time for questions and discussion. So just to tell you a little bit about myself, I was born and raised in Florida. As Nabila noted, I came to New York City when I was 17 to go to college. I became activated around issues around sexual and partner violence, became a rape crisis trainer, and determined that I really wanted a career in preventing violence, particularly preventing violence against women, sexual violence, partner violence. And this really became my purpose. So I went to the School of Public Health, got my master's in epidemiology, eventually got my doctorate in sociomedical sciences, and have really been rooted in Upper Manhattan ever since basically the mid-90s, and this is where I raised my family, where my kids are educated, and where I really cite my research, education, and activism. And so, like many of you who are trained both in quantitative and qualitative methods, I sort of toggle back and forth from this, macro level to the micro level, but following a very typical cycle of investigation to intervention. So we look at the global data, the national data. We then begin to identify sort of the local epidemiology, risk factors. Why are some groups and subpopulations more affected? What are the inequalities? Are these inequities? Can they be prevented? And then in order to design those interventions, we really need good, rigorous studies that give us information about causality, right? Causal inference is tricky. And then we engage in more research, mixed and formative methods to design the interventions and then testing them. That's another tricky area, using experimental, quasi-experimental designs. So that is very much what I do. And like many of you, I use two critical models or theoretical frameworks to inform all of my research. So the socio-ecological model is something I know that's familiar to everybody, this idea that, individuals are nested in multiple levels of the social ecology. And my work really focuses here at community and community spaces and peer and relationships, friend relationships, but always really trying to understand how are these spaces related to social systems, specifically social systems of stratification and oppression? And this is really important to keep in mind, that it's not just about working with communities, it's also about what kind of community level interventions can be designed that are going to disrupt social systems of oppression. And these social systems of oppression typically that we are all very interested in disrupting work around issues of race, ethnicity. So the race system, white supremacy, the gender system, sexism, the social class system, classism, and how are the interventions that we're designing actually able to potentially disrupt or unbalance those systems. And the important thing about the systems to keep in mind that we all know is that they are designed to keep certain people on top, other people on bottom, and that is the function of the system. The system wants to maintain that. And so if we're interested in disrupting that, it's definitely a heavy lift. So transitioning into what we're going to be talking about in terms of the research that we've been doing, I just want to get us all on the same page in terms of epidemiology of HIV in the US. So the HIV prevention community level interventions that we've been designing have been focused on preventing HIV. And in the US, the HIV epidemic is concentrated among gay, bisexual, same-gender loving, and other men who have sex with men. And within that subpopulation, African-American or Black MSM are at particular risk. They make up about 40% of new cases nationwide. And so in this area, as in the other area that I study, intimate partner violence, followed the same sort of trajectory of doing the research, from looking at national data, conducting a multi-level social epidemiological study, New York City M2M, in order to characterize these pathways of influence from higher community level and neighborhood level down to the individual level, to characterize the racial disparities and hopefully identify these mechanisms that we can then intervene on. And the results of this very sort of long, arduous road to understanding was that homophobia and stigma are negatively associated with positive outcomes, right? So they drive serodiscordant, unprotected anal intercourse, or they're associated with it. Again, cross-sectional study, I want to be careful about causal inference. And we also found that neighborhood attachment, gay community attachment was associated with lower anxiety, and that neighborhood level gay presence was associated with lower levels of serodiscordant, unprotected anal intercourse. This strongly suggested that looking at community level social norms, looking at gay presence in a community could be potentially impactful in terms of designing interventions. We also found that in our sample, about half of the young Black MSM had not tested for HIV in the past 6 months. So we began to think about what kinds of interventions could we design to address this. At the same time, the national Ending the HIV Epidemic program and strategy is taking hold. And it's really focusing on two approaches. One is treatment as prevention. So for people who are living with HIV, the idea is to move, to support them in moving along the HIV care continuum from being diagnosed to being virally suppressed. And we know that that's really important because the data continuously shows us that 80% of new infections are transmitted, unfortunately, from about the 40% of people who are living with HIV, but are not diagnosed or not in care. And we also know now that if you are undetectable, you cannot transmit HIV sexually. And that is really critical. For people who are not living with HIV, we have biomedical prevention, which is ART reformulated and repackaged as PEP and PrEP. And that is medication that you can take that will prevent you from acquiring HIV if exposed, or if you are exposed, that you can take for 28 days after exposure. If you take it, start it within 72 hours, and will prevent HIV from taking hold. So these are the two approaches. And so what is important about this is that HIV testing is the gateway to both of these approaches. So HIV testing has, really becomes very central in our strategy. 2012 was a pivotal year. So just as we had finished New York City M2M, where we had invested a lot of time and energy in understanding HIV risk factors, specific HIV risk factors and HIV risk behaviors, sexual behaviors in particular, there was a sea change in the context around HIV prevention. We learned then that that optimally someone who is positive will start ART immediately, and that became the standard of care. HIV self-test kits were FDA approved and hit the US market, and PrEP was FDA approved. And PrEP, that was a watershed moment. It meant that if you were negative and you were able to take this medication, you could prevent yourself from getting HIV. But we had continued racial disparities in HIV testing and continued and growing racial disparities in PrEP evolved over time. So again, it really emphasized the need to address and increase uptake of HIV testing and PEP and PrEP, but also to focus on what are the malleable factors that we can intervene on that would contribute to that. And so we as a team really began to focus on HIV stigma and homophobia as two intersecting forms of discrimination that could be addressed at various levels and could potentially increase access to HIV testing and PEP and PrEP. And what we know about HIV stigma is that it reduces uptake of HIV testing. The empirical evidence on this was pretty clear. Similarly with ART, internalized stigma was associated with lower uptake of ART, and the evidence was beginning to emerge around PEP and PrEP stigma as well. And the research on homophobia was very similar, that it acted as a barrier to testing, prevention, and treatment. Unfortunately, HIV stigma was with us from the very beginning of the epidemic. This is a shot of the front page of the New York Post where the person who supposedly brought HIV to the US was vilified and scapegoated. Later, research coming out of the New York Blood Center determined that HIV had been in the US long before so-called patient zero had arrived. But HIV stigma was prominent from the beginning and always acted as a barrier for people living with HIV and for people not living with HIV to full health and wellness. So focusing on HIV stigma and homophobia was our goal, and we were very happy to be awarded an R21 by NIMH to conduct challenge HIV stigma and gain empowerment. Challenge HIV stigma and homophobia and gain empowerment. This was our study team. It was, as I said, funded by NIMH, and the goal of this community level anti-stigma and homophobia intervention was to reduce stigma and homophobia, to increase access to testing and PEP and PrEP. And the idea for the R21 was to assess feasibility, acceptability, and preliminary efficacy using a quasi-experimental matched community study design. So we had two neighborhoods in Brooklyn, both were largely Afro-Caribbean, Black, African-American communities, and they were not adjacent to each other. One was the intervention community, the other was the control community. And as you would expect, we implemented the intervention in the intervention community. These are my close collaborators and co-investigators on the study who I know are out there in the audience. I want to note that very typically when we present this research, we present as a team with Mark Page and David Matthews. And so I'll just wave hello to you out there. Stephen Gordon was a key member of our team and who now, unfortunately, is no longer working with us, but is still part of our family. So change was also a partnership with multiple community-based organizations, GMAD, Gay Men of African Descent. In fact, Vaughn Taylor Kutuga was the co-PI on the study with me. Bridging Access to Care, which used to be Brooklyn AIDS Task Force, CAMBA, which is a major social service organization in Brooklyn. It was, as with all research, a cast of thousands. So I really want to just, note that here. Okay, so what was change? It was a multi-component community level intervention. It had three main components: workshops and trainings for community organizations, businesses, and residents. We also had space-based and pop-up events. They were very arts-oriented, sometimes theatrical, and they were focused on educating people and raising consciousness. And I'll talk about what that means in a moment. We also had a universal prevention message through a bus shelter media campaign. And broadly speaking, the pathway of influence that we were really guided by was this idea that community level stigma and homophobia increase things like concealment of sexual identity, concealment of HIV status, non-disclosure of HIV status, anticipated stigma related to HIV, but also related to disclosing identity, rejection from family and community, feelings of shame, which then reduce uptake of testing and prevention, increases one's individual level risk of acquiring or transmitting HIV, which then increases community level viral load. When we thought about stigma, we really thought about it as a dynamic social process. It was not just sort of a static marker. It's this idea that it's a process and thus it can be interrupted. So there's labeling, stereotyping, separation, discrimination, and outcomes. And this is based on Phelan Lincoln DeVideo's model. Also how it functions to keep people in. So a lot of times communities think that they don't want someone to identify in a way that's stigmatizing, because if they don't, it keeps them in the community and keeps them safe. Sometimes it comes from a place of real love and desire to protect someone. Other times, once someone is identified in a way that could threaten the community, they get expelled from the community and they get pushed away or out. But it's also important to remember that stigma and the stigmatization process and discrimination is part of the system's function. It's a mechanism that helps maintain the system's function to keep whole subpopulations of people down, right? So that's the function of the system. There are different types of stigma: internalized, self-anticipated, experienced, enacted, and of course, community, which is where we were focusing. The intervention mechanisms that the change program focused on were enhancing visibility, increasing contact. We did a lot of education on the stigmatization process and its effects on health and well-being, particularly focusing on young people, children, and adolescents. Increasing empathy through perspective taking, and I'll talk a little bit about the activities that we engaged in to do that. Raising critical consciousness, again, drawing corollaries between homophobia and keeping gay people down as a group and racism and white supremacy, for example. And this really resonated because as we were implementing change, Black Lives Matter movement was spilling out onto the streets of New York City. Literally, the FDR was being shut down, and people were very open to understand, drawing that association between sexism, sexual orientation-based discrimination, and racism. We also focused very intensively on teaching skills as much as we could to interrupt stigma and homophobia. So providing specific instruction, language that could be used, that couldn't be used. There were a lot of questions about that. And then with CBOs, really doing 360 of the organization to try to understand what policy practice and practice changes could be implemented to reduce potential experience of stigma and discrimination at the site. So for every one of our components, we had a model of change. And so this was our model of change for the workshops and the trainings. I'm not going to go through it. We have a lot to get through. as I said, we had fixed events and pop-up events. So we had a gay space at Brooklyn Men Connect, which was in the intervention community. And this was a space that increased visibility of gay people in the community. It increased the probability of contact. Contact is an incredibly important anti-stigma mechanism because it humanizes people. When you have contact with someone from another group that you've been told or you believe is immoral or are bad, it humanizes them, you are humanized to them, and it reduces the segregation that is so effective to keeping these systems of oppression in place. It offered a safe space to LGBTQAI+ and people living with AIDS and HIV in the community, accurate information, education, also increasing access to HIV testing and prevention services. And so just to note what this picture is of, this is a huge lucite box, which we borrowed from Canva, and we used it for an event called Walk in Our Shoes. And the idea was that the community member could bring in a pair of gently used shoes. They would get a coupon for $10 off of a new pair of shoes at Payless. They would engage in some education, maybe eat a sandwich, come inside the site, take a look around, get to know it a little bit. And the box was filled with 181 pairs of shoes to note the 181 new cases of HIV that had occurred in that neighborhood in the last year. So it was educating, it was visually representing, and it was increasing perspective taking and empathy. This is a pop-up event. We went around on Valentine's Day and did mini trainings with people on the streets, giving out condom and safe love packs. The workshops and trainings overall, we came into contact with about 900 people and trained 3 CBOs. Our trainings lasted anywhere from 5 minutes to 2 days. They were structured and manualized. We had 2 to 3 people delivering them. So Mark Page, myself, and Stephen Gordon. Mr. Page is trained in theology, and as you know, I'm sure people like to cite scripture in defense of homophobia. So he was especially able to discuss that with them. Stephen Gordon was a social worker, and I provided some of the epidemiology and some of the empirical data in the trainings. And again, it was focused very much on skills and really alternatives that one could engage in at each step in order to interrupt the stigmatization process. Our bus shelter ad campaign was really well received. We were able to use one of GMAD's, or this actually was Canva's image, and create new text. And we were covered in Brooklyn 12 when it was launched. So how did we evaluate? So this went on for about 9 months. And what we did in order to evaluate the impact of this on the community, again, the matched community control design, the intervention community, and the control community. We conducted serial cross-sectional surveys through Street Intercept. And so in each community, before the intervention and after, we intercepted people and interviewed them about their attitudes. But we did it in a very rigorous way. We randomly selected blocks. We enumerated every block in each community. We randomly selected blocks from each one. Teams of trained surveyors went out and they intercepted all passersby. Of course, we had some, self-selection in bias. We ended up conducting 860 surveys pre-intervention in June 2014 and 585 post in June 2015. We kind of chopped up some scales, I hate to say. So if the measurement questions, you're not going to be happy to know that we did, when you stop someone on the street for 5 minutes, you can't ask them a 20-minute scale. So we did, draw some questions from different measures. And our analysis involved doing GEE models with propensity score matching to evaluate the impact on the community level attitudes or social norms. We also analyzed pre and post intervention administrative HIV testing data from the BMK storefront. Okay, so this was the change study. It was a while ago. And what did we learn? Unfortunately, our GEE models indicated that we did not see an interaction between neighborhood and time in terms of HIV stigma at the community level. So we did not see a significant decrease in our intervention community as compared to our control community over time. And similarly with homophobia, we did not see that association, which is what we had hoped we would see. But what we did see was a massive increase of HIV testing at Brooklyn Men Connect, at the intervention space that was specifically, there to increase visibility and increase access to testing. So we saw a 350% increase in the summer, the quarter after the intervention. And so, what are some threats to, oh, well, okay, great. So you maybe didn't see what you would hope to see in terms of impact on attitudes. What did you see in terms of actual uptake of testing? Well, that's very positive, but perhaps it was part of a trend. Perhaps every neighborhood in Brooklyn experienced that, and we really don't see that when we looked at historical data on HIV testing in Brooklyn from 2013 to 2015. We didn't see that. So we're left with these sort of, well, did our intervention work? Did change work? Of course, we think it did, but that we weren't able necessarily to detect that using the methods, the evaluation methods selected. And it could be for several reasons. It could also not have worked. So for example, it didn't work because there really wasn't enough penetrance. There wasn't enough intensity of the intervention. Maybe the spatial boundaries for the neighborhood was too big or the effort was too weak. There could have been contamination from the intervention to the control community. While these neighborhoods were not adjacent and they were sociodemographically similar, there were connections between them by people, kin, social, and then bus networks ran through them, which is, when we had a bus shelter ad campaign, this was something that was unavoidable. There could have been a positivity violation where there's a mismatch between the community members who were sampled for the evaluation and those who got the intervention. So we stopped people on the street and we asked them their attitudes before and after the intervention, but we don't know if they actually had contact with any of our intervention components. We did ask some questions about it, which I can go into later. For example, around the bus shelter ad campaign, had they seen it, et cetera. It is possible that it worked, but there was a lagged effect. So if we were funded to go back and to evaluate, or we had a way of evaluating the staying impact of something like this, maybe we would see a lagged effect. And it's also possible that, yes, it did work on testing and access, but that it wasn't via the stigma or homophobia mechanisms that we measured, or just the way that we measured and assessed it wasn't able to pick that up. So the point here is that there are enormous measurement and methodological challenges in evaluating community level interventions. So with the sort of the great lift, the effort that was required as part of the intervention, but evaluating it is really, really hard. So why is it so hard though? One of the things that we have at the area level, for example, I can tell you how much tree canopy there is. I work closely with Andrew Rundle on this new project Charge, and he can tell you how much tree canopy there is. He can tell you how much litter there is, but nobody can tell you how much HIV stigma or homophobia there is at the area level in New York City. So we don't have archival data on area level attitudes. We also were not necessarily able to assess if there would have been a similar uptake in HIV testing if we had had a drop-in center in the control community, but that didn't have the change intervention because there wasn't such a place. But we didn't, as we said, see a secular trend and increase in HIV testing. So we don't think that that was as big of an issue as it could have been. Again, the issue of measuring lagged effects or reciprocal effects, and the issue of the positivity violation. So how do we address that? And so this is sort of one of the things that we're trying to do in our new study, which is called Charge, and I'll lead into that in a moment. But over time, since the Change study, new stigmas have emerged. For example, PrEP stigma emerged very strongly in the years following FDA approval. And although there's been quite a bit of pushback against it, it's still a great concern. While we sort of conceptualized the pathway from stigma and discrimination to outcomes as somewhat linear, the reality is that it's very reciprocal and it's nonlinear. So we really need methods that capture that complexity and the reciprocal nature of these mechanisms within systems, but also capture the full system. We also concluded that operating at a single level, even just at the community level, is insufficient. We really need to be thinking about multi-level interventions if we're going to have really move the needle and have that big impact that we're looking for. We also, in recent years, due to COVID, find that there's an accelerated trend toward virtual and online communities. This is something that I had a really interesting conversation with someone earlier today about, just this idea that, you know, people are experiencing these negative stigmas and discrimination in virtual space. And is that different than experiencing it in real life? And then, of course, the issue of white supremacy and how systemic racism just fundamentally conditions, as this massive exogenous super system, fundamentally conditions all of these nested stigmas and discrimination around HIV, around PrEP, around testing. And so, you know, how do we design interventions that take all of this into account, but also don't overwhelm us in trying to do more than anyone can do in a single intervention? And I think I'll pause there and just say that I think that's an important point for us all to remember, that these are interventions that are focused. They're often focused on a specific thing, a specific type of stigma or discrimination, but the movement is definitely towards addressing intersectional stigmas. And that's what CHARGE is all about, the study that follows from CHANGE and that we're doing right now. But these are just studies in research that potentially will turn into interventions that will be implemented in social service organizations, but they're part of a broader effort that we all engage in to disrupt these systems of oppression. As a researcher, you have to know what your research can do and how it can affect change, and you want to push that as far as you can. But I think we also have to appreciate that there are other ways of affecting change, and that we engage in those as well, and that we situate our work within that broader context as well. Okay, so that was CHANGE. We were subsequently funded to conduct CHARGE, which really attempted to extend the CHANGE model in order to identify novel components that we could add to CHANGE that would address intersectional stigmas, specifically PEP and PrEP stigma. And what we also proposed to do in CHARGE was to use a method that tried to capture that complexity, that really tried to understand the whole system, and identify specific loops or reciprocal subsystems that could be intervened that could potentially disrupt the whole system's apple cart. So we'll talk about how we did that in a moment. But again, just to summarize, CHARGE is challenge HIV, stigma, homophobia, and racism and gain empowerment. The study is underway right now, and our goal is to, again, assess feasibility, acceptability, and preliminary efficacy of the novel intervention components that we design as part of this study. I, again, want to recognize the incredible study team that we are working with. As with all research, it's a cast of thousands, but I really have to call out MOBI, Mobilizing Our Brothers Initiative, and Deshawn Usher, who's the executive director of MOBI. Deshawn and I have worked together now for over 10 years, probably more. He was at the New York Blood Center. I was at the New York Blood Center. And he now runs this amazing organization that curates cultural events for gay Black men and queer men, and people, I should say. We have a wonderful team: Nassim Sambuchi, David Lounsbury, LaRon Nelson, Andrew Rundle, Mario Guatz, and Dustin Duncan. And again, in the audience, I know are David Matthews and Mark Page, who are co-investigators with me on this study. And the three of us really manage everything for the study. Okay, so what is CHARGE doing that's so unique? Well, we're using system dynamics in order to try to, as I said, characterize a system and then identify specific processes within that can be intervened on in order to disrupt the broader system. And so specifically, we're interested in disrupting these stigmatization processes. System dynamics modeling is increasingly used in public health. It's appealing because it really tries to characterize the complexity of whole systems. So it, identifies different components, subsystems, how the factors within the systems are interdependent. But it's complicated and it's a lot. I mean, even looking at this, you're probably thinking, wow, that's a lot of arrows. But it's in the system science methods toolbox is something called group model building. And within that, it's a participatory method where you get a lot of people together to sort of brainstorm and come up with a characterization of a specific system. It draws on sort of CBPR principles, and you really want to make explicit in these models these feedback loops and structures that help to reinforce or perpetuate the outcomes. So again, how is the system being maintained? You want to identify those little loops that maintain the system. So we applied system dynamics using causal loop diagramming, which is another tool in the group model building toolbox, to qualitatively identify these feedback loops. And so again, the goals were to identify specific places or levers where we could intervene, and that intervention would result in a big impact on the larger population. And so this is actually a systems dynamic group model building project from David Lounsbury that looks at looks at impact on HIV incidence of things like testing, uptake of PrEP, uptake of PEP. Embedded within this very complex model is a little box that says HIV stigma. So our goal was to open up that box and do causal loop diagramming to really characterize and explicate what's in that box. Okay, so once we did that, our goal was to, and I'm just going to draw your attention to the lower portion of this slide, to take those results and then to ideate, prototype, and component test a novel intervention component that would be an anti-intersectional stigma intervention component. So how did we do this? Well, first, we conducted focus groups and in-depth interviews with 80 representatives from the focal community. And these were two communities, so gay, same-gender loving, Black, MSM, as well as community-based HIV service organization representatives. And so we conducted focus groups and interviews. We used scripts from the system dynamic modeling and causal loop diagram modeling toolbox, and interviews were all recorded and transcribed, and then the data was analyzed. The data from this that moves eventually into the causal loop diagrams is text data, and it's coded. So it's like qualitative data analysis, but it's a little different with themes, causes, and effects. But you use multiple coders, so you want to, achieve some sort of iterative reliability. And then you use a program called Vensim to visualize the feedback structures that emerge, and you assign positive or negative signs to the various links in your model and determine whether the loops that are, or the cycles that are identified are either reinforcing or balancing. Okay, so we did that. This is characteristics of the 80 people who participated in our focus groups and in-depth interviews. They were uniformly gay, same-gender loving, Black or Latinx men, mostly African-American, mostly gay or same-gender loving, well-educated in general, and about half were living with HIV. So as with all qualitative data, we identified sort of thematic areas that gave rise to the causal loop diagrams. One of the big ones that emerged was medical racism and medication mistrust, really focused on doctors not knowing enough about a medication that's being prescribed, like PrEP, feeling that pharmaceutical companies are targeting people of color, that people, when they're taking PrEP or medications, might feel like they're a guinea pig, that it's a setup, that there's a history and a current experience of people of color, Black people in particular, Black women in particular, being experimented on and being afraid to go to the doctor because of this experience, both historical and current. Things that also emerged were things related to medical racism and medication mistrust, focused on things that can make it better, representation. So this idea that representation matters, seeing people who look like you as a physician behind the counter, a Black gentleman, another Latina made someone feel much more comfortable. In addition to medical racism and medication mistrust, which emerged very strongly, the intersectional impact of stigma, racism, and homophobia, and its internalization. The idea that it's within community stigma and discrimination that can be extremely damaging. And that the disappointment that you might bring upon your community. One person said, "You feel like I've made myself a statistic. It's my fault. And I've let down myself, my family, and my community by not taking care of myself." So the internalization of that and that intersectional aspect is what's really important there. And the idea that it's bringing, shame upon the community, but that a lot of the negative discrimination is coming from within the community. And then, of course, the role of trauma. So this is just a tiny little snippet of the qualitative data that we collected, but that informed these causal loop diagrams. And so these data were called quotes, and they were entered into an error table they were organized and coded in an error table. Again, we assigned the direction of relationship between a cause and effect with a plus or minus. We engaged in some activities to make sure that we had good inter-rater reliability. And then we met as an analytic team every week. And I have to say here also, Priscilla Zito, public health student at the CUNY School of Public Health, and David Matthews were the two analytic team leaders, and they really did an amazing job analyzing this data. And so they developed these initial plausible relationships, and then we would meet each week to discuss them, refine them, and then resolve coding discrepancies. So this is a very simplified picture of just one part of our causal loop diagram. This is a little close-up zoom in, and I'm not going to spend a lot of time on them because when we've presented them in the past, we find that people find them extremely overwhelming and not very helpful. So it is the kind of work that often is most meaningful to the analysts who are doing it until you get it distilled to something that's very simple and really resonates. So this is a picture of what I hope that is. So this is our loop called medical mistrust and HIV transmission. And it really connects gay Black men's experiences in healthcare to their engagement in healthcare, as well as disclosure of sexuality, impact on testing, disclosure of status, transmission, et cetera. And so this was the CLD that we worked with Moby on to develop one of our novel intervention components. So I'm going to talk about that a little bit, and then we'll wrap up and I can take some questions and comments. And so once we had created several of these CLDs and we workshopped it, we ideated with our fabulous team, we began to think, well, what are some of the ways that we can communicate this and communicate where in these, different linkages we might be able to intervene in order to disrupt this cycle. And what's important here is that this is a reinforcing loop. So it's the decreased trust in medical professionals reduces disclosure and self-identification, which then increases hiding of sexuality to healthcare providers and others, which then decreases access to testing and prevention. So how do we actually, this came out of our data, we developed this model. How do we disrupt this? How do we throw a spanner in the works in order to unbalance this so it's no longer reinforcing? Because the reinforcing model maintains the structure of the system. It helps the system stay in place. So the Moby team came up with a brilliant idea, which they called a story within a story. And the idea is to use dramatization and narrative methods to storytell this causal loop diagram. And so they hired professional actors, and Julian Walker was the lead on this, and he developed the script. And the script actually integrated some of the text data from the causal loop diagrams, and it focused on the reinforcing loops and really explicating those moments where the stigmatization process was unfolding and what could be done, hopefully, to interrupt it. The scene that was created was called Check-In, and these are the actors who were in this scene. Again, they're all professional actors, most were gay Black men, have a transgender woman of color who was the receptionist for the telehealth visit, which was what the scenario was about, scene 2. And the idea was that mistrust and anticipated stigma, really reduces the likelihood that someone's going to seek care or testing and get on PEP and PrEP. And one of the key solutions is representation and being treated by other people of color and or gay or same gender loving providers. And that was something that emerged very powerfully. It emerged in the data, and then it was reflected in the scene. The scene was of a young person who was partnered with a slightly older person. It was a serodiscordant relationship, and they were having a telehealth visit, and they were checking on their STI status because they had had sexual contact with someone during the sort of beginning stages of the relationship. They were very self-conscious about it, very nervous about it. In the scene, the physician who's played the Dr. Ronald Forrest talks about the complexity of relationships, talks about, the sexual dynamics that are often implied in sexual relationships, and even talks a little bit about how heteronormative that can be. And so we had this event on November 18th. And there was another scene that we don't have time to talk about, My Girlfriends, which really was talking about the intergenerational transmission of stigma across 3 generations of gay Black men. And 60 participants registered. We think that we know between 30 and 40 attended for the duration. And we were able to do a post-event discussion group. This was our pre-pilot. And do a post-event discussion group held by Mark Page, where we got some wonderful feedback. And we are working with our, as I call them, our sort of evaluation brain trust to figure out how are we going to evaluate the impact of this intervention on a broader community in a way that is efficient and conserves resources. Before we get to that, I just want to, provide some of the feedback from folks. They all said that the characters were very relatable because we know someone, or it's ourselves, someone we know closely. And so they said it was engaging because it helped them feel things. And it is a very emotional, the scenes were recorded. I should probably have made that clear. The actors workshopped it. They workshopped the dialogue, and then they were professionally video recorded. But they were video recorded in the Zoom environment. So it was really kind of meta because it was a Zoom within a Zoom, because our event was a Zoom event. But it was very appropriate for the times that we're living in. And feedback was that it was identifiable. Being a Black gay man, you fluctuate between different people within the community. I've experienced all of the characters, or I've been multiple characters. And I think for us, that was really powerful, that people were able to see themselves in the different characters and potentially see the the evolution, but also see where maybe some of the things that they said or did were not particularly helpful when they were in that character or when they could identify with that character, and what are some things that they could do differently either in the future, or how do they communicate about that to other people in the community. So that's where we are with charge. We are integrating the new component into change, but that part of our study is compromised because of COVID-19. A project like Change could not have happened in the last 2 years. We were on the streets every day, making contact with people, running our trainings, walking into barbershops and beauty salons, convincing the barber to let us come in. Mark and his team would do mini trainings in barbershops where we would offer $5 off a cut, and the barber would let us in, and we would do a little mini training in front of the clients. That can't happen. Nobody wants, everything is being limited. So we're really looking at online and virtual programming in the future, but this has really changed the type of study and the type of program that we wanted to evaluate. Where we're moving is that we're going to build out this event using multiple media-based approaches, developing teasers and recruiting a much larger sample. So we're looking at clips of the film scenarios being produced for TikTok, getting influencers through Cameo, but also through this incredible network of people who are working on the study already, developing reels and Instagram stories. So really building it up, as you've seen, I'm sure, on your own Instagram feed, as if it's a premiere of a film. And then re-implementing it and evaluating it this time with some of the methods that we would like to use. So we need to leverage the actors and their networks. We need to edit and adapt the manualization of the debriefing. It was an interesting sort of point of tension between the Moby team and the researchers. And the Moby team was sort of like, and this is why nobody wants to go to your events, because your, post-event debriefing is so structured and it's so pointed, people really just want to be engaged. So we really sort of experimented with different approaches to see what would be more engaging. And then we need to conduct a full pilot. And as I said, we need to evaluate it using metrics, social media metrics, in-event sentiment analysis, and pre and post attitudinal assessment. So this is what we're looking towards. So that is the story of Change to Charge, the community level anti-stigma and homophobia intervention that sort of morphed into an anti-intersectional stigma community level intervention, and how we have fared during COVID. The challenges inherent in evaluating community level interventions and programs are enormous. I hope that I was able to draw some of those out and identify them. We don't have all the solutions. If you have any, we are open and would love to hear from you. I really want to pause right now and just to acknowledge and say thank you to the participants in our projects and our studies, the study team, the volunteers. There were peers at Brooklyn Men Connect who worked tirelessly on this project. We had Columbia students, we had CUNY students who worked with us. And we see this work as very much tied to liberation movements. And this sort of returns back to the idea of the broader systems. Our goals as a research team is very much to identify interventions that are going to disrupt the broader system. And in so doing, we hope that we improve the lives and health and well-being of the folks who come into contact with the programs. And we like to think that we are doing that. And so we will, keep trying. And so these are some pictures of the Queer Liberation March from a couple years ago. And I thank you very much for your time and look forward to your questions and our discussion. I will stop the share.
Yeah. Thank you very much, Dr. Frye, for a powerful presentation. And really, what I like about your work is how you use science to make a difference in people's lives. So I want to start with my question first to you. You have been doing this work for at least 15 years, investing in community-based research, collecting data, and really you worked in different settings and agencies. I wonder if you could tell us a little bit more about how your scientific papers, how your really reports that you created either at the Department of Health or other settings influence social policies and social change. I mean, you have been doing this work for so many years. What impact did you make on a macro social policy,
Right.
social change? If you can tell us more, that's my question, and I will turn to
Sure. Yeah, no, that's a good question. It's a hard question to answer. And it's right. It's, what we're all going for is, really making an impact, especially in terms of social change. So I have to say that some of the research that I've been really privileged to be a part of in intimate partner violence and sexual violence, I feel like those have really had very clear impacts. When I was at the health department, our femicide report, this was under the Giuliani administration, it's that long ago, was actually suppressed. And the city council called hearings so that we could present the data to the city and demonstrate that intimate partner femicides had not been decreasing at the tremendous rate that overall homicides were decreasing. It resulted in some funding going to a community-based organization, Connect, that unfortunately, it has morphed and it's a wonderful organization now, and it still does gender-based violence prevention programming. So, we've had an impact there. At that time, I was also part of the 13-city intimate partner femicide risk factor study, which identified having possessing a weapon in the home as being an independent risk factor for completed intimate partner femicide. And that led to changes in state law, statutes, precedents around removing guns from batterers who'd been convicted of felony or misdemeanor domestic violence crimes. So, these are clear impacts. In terms of the HIV intersectional stigma, I would say that we have really moved the needle in terms of communicating to the NIH that we need resources focused on how to evaluate the impact of HIV stigma interventions and how to measure intersectional stigma, period. So the NIMH has actually been conducting a series of workshops and meetings that we have been, and I say we, meaning our team, but also the broader anti-stigma community that have been, we've been participating in them. And they've developed now a toolkit, a intersectional stigma toolkit, which you can access online, which provides a number of really good tools for researchers and programmers to use. But what we really need actually are some investments in area level measures of HIV stigma, homophobia, some of these social norms that we know are so important to HIV testing and PEP and PrEP uptake, but that aren't being measured. And that really prevents us from doing a good job of evaluating our community level or even multi-level interventions. So I feel like that has been an impact. And then I'll say in terms of HIV self-testing, the TRUST study, and then just uptake of HIV self-testing and scaling up. I've been part of the WHO working group on that. And I am a firm believer in the power of self, managed care and well-being. And so I think that has been contributing to the evidence that has led to scale up of HIV self-testing globally is something else where I think we've had an impact.
Thank you. Thank you. So there is one question from on the chat asking, can you use van rather than storefront for HIV testing? What do you think, and have you tried it?
Oh, yeah. No, I ran a whole HIV testing program where we used a van. And it's a very effective way of doing HIV testing. But honestly, in our current climate, it's not the way to go. It's where we're at right now is it's all about self-testing. And in fact, I think many people are looking at, and our new, hopefully, knock on wood, R01 that we hopefully will get, looks at HIV self-testing and packages it with other STI specimen collection and other good stuff for people to engage in self-determined, do-it-yourself sexual health care. Because a lot of folks don't want to get on a van with somebody right now, right? I mean, even the COVID testing is outdoors in a tent. So it's been done, it's effective. We know that it's a lot of work having run a program. I can tell you it's a lot of work. But right now during COVID, it's probably not going to be a great focus for resources.
Building on this question from the same person asking about what is unique about the van rather than storefront to increase HIV testing? Yeah, now we're experiencing COVID, but from your own experience, have you used van? What are the strengths of using a van going to different places and engage people in treatment?
Yeah, I mean, what I'll say is that there are weaknesses with any kind of fixed space, even a van space, which isn't fixed, because any space can become stigmatized, right? And as soon as someone knows what the purpose of a space is and it's associated with a stigma, it can become stigmatized. So van, fixed, tent, if it's stigmatized, that's a barrier. But obviously, I mean, not obviously, with a van, you can go to any neighborhood, you can go at different times of the day. It has enormous advantages over a fixed space. However, I will say what we did in Change, and again, David Matthews is out there in the audience, he was running the BMK space. He said that he thought Change really helped the space come out to the neighborhood as a safe space and not a stigmatized space. And I think that's what's really important, is that vans, even ways of testing, don't solve the stigma problem. The stigma problem can only be solved through anti-stigma interventions and anti-stigma work.
Mm-hmm. Thank you. There's one question about your work with transgender. Have you done this work, and can you tell us about what your interventions or prevention models, what kind of findings you found that would be important to disseminate to the community?
So I do not focus specifically on transgender communities. However, within all of our work, all are welcome. So in Change, people who came to get tested, whether you were, straight or gay, what your gender identity was, what your age was, you would get tested. You would be invited into the space to participate in the activities. I do have some research in sexual violence prevention with with men, both cisgender and transgender men. And what we do find is that there is a high rate of sexual violence among transgender men, and that is a population that's very much neglected by the sexual violence prevention world. Men are neglected, but transgender men in particular. So that is an area where I'd be interested in working with collaborators to do more work.
So building on the same question, what is the ideal HIV intervention with transgender? If you have access to funding and you want to build on your scientific knowledge and your findings and many years of experience, the question here from the audience, what would be your next really important study with transgender that you would pursue?
Right. Well, I think working with women is whether cisgender women or transgender women is really, really critical. I think it would be fantastic to conduct research with any woman or femme identified person, and that would then sort of organize the intervention around gender identity and would take into account the unique needs of transgender women and cisgender women. PrEP uptake among women is not great, and PrEP uptake for transgender women can be really, really powerful and impactful. And so I think that would be, some kind of a PEP and PrEP uptake intervention. But I also think it's really important, and I'm glad you raised it, all of the research that I do on HIV prevention with gay Black men, I multiple PI with gay Black men. And I think it's really important that the studies are run by people who represent the communities that are focused on. And so I really also think that we need to do a better job of bringing transgender women into the research community and working more closely and more respectfully with the community. And that's something that's a real struggle. There are a few leaders in the field, but it's definitely an area where we need to improve.
There are two questions related to COVID and impact of COVID on your research. One question is related to transgender, and the question is how COVID-19 or access to vaccination impacted transgender people, and have you done anything? And the second question, it has two components. What impact COVID had on stigma? Did you expand telehealth, telemedicine to reduce barriers of accessing care? As you know, there are a lot of telehealth prevention, intervention that's working well, reaching people when they're at home. And have you used it? Have you thought about it? So the question is about the impact of COVID and strategies to address it with really innovations like telehealth.
Right. So the scenario that we talked about depicted a telehealth visit between a young person, his partner, and the physician. And there was the receptionist and the nurse, receptionist nurse was transgender woman in that scene. So yes, telehealth has definitely removed barriers, and it has forced many of us and many healthcare providers to remove other barriers that might have been in place before COVID, but they sort of determined, well, maybe we don't need that much of a workup. Maybe PrEP eligibility can be established using this. Maybe we don't have to have you visit every 3 months. Maybe it can be every 6 months. So that has been very positive, and that has reduced some of the barriers via telehealth and loosening of some of the restrictions around being on PEP, being on PrEP, et cetera. In terms of stigma, I do think that it's gone both ways. I mean, if you're stuck at home and that's the only place you can do telehealth visits, but you're not out to your family or you're not out to the people you live with, either about HIV status or about sexual identity, about your gender identity, you're still going to have challenges in communicating effectively with your healthcare provider or others, or accessing the services you need. So while there have been some pros potentially associated with, the blossoming of telehealth due to COVID, there's definitely still some cons that need to be coped with. In the new project, we're really, again, sort of taking on this idea of do-it-yourself healthcare, where individuals are able to manage as much of their own healthcare, specimen collection, HIV, STI testing as possible, working with people virtually to maintain sexual health. So, we are playing with this idea that we need to better develop that as an intervention for particularly vulnerable populations. But we haven't, tested that yet.
So building on this question, do you believe in telehealth for the population you're working with? Do you think they have access to it? And do you believe there, or you have seen, or you experienced, or you heard from your people you're working with and challenges and barriers of accessing telehealth?
I mean, yes and yes. I mean, it works for some people, it doesn't work for others. Some people have barriers, others don't. And I think that's really the challenge, is creating approaches that are going to meet everybody's needs. And it's a completely changed environment now. I do want to emphasize, though, that our solutions and our interventions are not just about getting people to healthcare. It's really focused on the community level norms, peer level norms that act as barriers, not just to getting testing and PEP and PrEP and healthcare, but to a lot of other things. HIV stigma and intersectional stigma is associated with negative mental health outcomes. It's associated with suicidal ideation and attempts. Those are independently incredibly important outcomes that intervening on stigma and discrimination, especially intersectional as, contextualized by white supremacy, can have a really powerful impact on. And so that's really what we're focusing on. It's, I sometimes get nervous when we distill it down to getting someone in front of a doctor so they can get a prescription, because it's not the solution for everybody, right? And intervening on stigma and discrimination prevents a whole host of negative outcomes, in addition to potentially getting someone to a physician or healthcare provider so they can take better care of their health.
Thank you. There is one question I want to raise it, and you may understand it better than I do, because I'm a little bit not sure about the question, but it says, in studying HIV/AIDS, could you speak to how you address stigma in the availability of scientific tools? Have we failed? And I don't know if the question, and that's why I'm raising, if the question about the scientific tool is our PrEP and other tool, or other intervention tools. I wonder if
yeah, I mean, I think I understand the question, and there's a lot of research going into trying to measure intersectional stigma, to measure different types of stigma, to measure intersectional stigma. In fact, in one of the studies that we're running, we're deploying an intersectional stigma measure that asks people about their experiences because of who they are. And we know that they are multiply stigmatized because of their self-identification and certain characteristics, with certain statuses. But when we ask that question, we realize we don't actually know what part of who they are is salient for them in responding to these items. So the measurement, the complexity of properly measuring intersectional stigma is massive. And then there is the evaluating anti-stigma interventions. Evaluating any kind of an internalized or self-stigma intervention, by definition, is going to be a little bit more straightforward, right? It's at the individual level. We have measures that we can deploy. It's a more controlled environment. Taking that to the community, the peer, the community, or multi-level interventions really ups the complexity. And when you add on to that we don't have measures of these important mediators, stigma, discrimination, at any level higher than the individual. We don't have it for families. We don't have it for peer groups. We don't have it for areas. Like I said, I can tell you about tree canopy and particulate matter. I can't tell you about stigma and homophobia in communities. I can if I use proxy data like crime data, but we know that's not very good, right? So I wouldn't say we've failed. We're working on it. And I want to credit NIMH has really dedicated resources and time and intelligence to this. And I appreciate that. But it has been, it's still very much a work in progress.
Thank you. In terms of the system dynamic approach that you presented and the diagram that you said it's complicated, and I feel like you believe in it, and I do believe in it. System dynamic getting into really help you to get as a scientist into important issues if you integrate the voices of the community and voice of the participants. And how the findings from the system dynamic really truly helped you to find the major ingredients for your intervention. Did you succeed, or still it's an exercise, which is a scientific exercise, or it's really a tool that helps you to identify culturally relevant community interventions? What would you say about these issues?
That's a great question. I do think as a method, it really improved our understanding of the dynamic and that reciprocal feedback mechanism. I think it helped elucidate things that we knew. And again, we have experiential experts on our team who can say, oh, I knew that was true. But the way that it shows up in the model, and then how that was interpreted into the dramatization, that was really unique and powerful. Is it superior to intervention mapping and other approaches that we've used in the past? We'd have to have some kind of head-to-head, right? trial. That's probably not going to happen, because I don't think that's a great use of resources. But it's an excellent question. And I would say, I do think it resulted in some insights that we would not have gleaned had we not used it. It is very intense resource and time and attention consuming. And this was just to develop loops, right? This was just to develop one system, one subsystem that would nest within that much larger system that I showed. And I think and theoretically, we could begin to use our work to do the simulations that the system dynamics is most famous for, is the simulation models, the mathematical simulations. I think, though, that we'd need a lot more information on the actual parameters and the quantitative relations between what we had in our loops. Ours, as I said, was qualitative, and I thought it was very useful, but would I propose that we use it to start simulations? Not yet.
Okay. There is one important question here. You, as a white researcher working with key populations, how do you ensure the voices of the population are centered in your research, given that you are a white researcher and not one of the community?
Right. Absolutely. So this is critical. And usually when I present this work, it's not just me. And so I'll say that we do team science, and the team presents this kind of research. We do multiple PI-ships. So the research that we are hopefully going to be conducting, I'm partnered with a gay Black man, Change partnered with a gay Black man, Dustin Duncan hopefully will be our MPI on the new study. The head of GMAD was the co-PI on Change. But that's, that can be nominal or it can be real. I like to think it's real. I really strive, and we strive to have as flat an organizational structure as we can. And we engage in a sort of, and I engage in a constant kind of self-auto-analysis of, is my white supremacy showing? And we talk about that quite a bit. And we talk about the tensions of the, sort of institutionally racist system of research, my role in it, and then, how that plays out in our team dynamics. So it's something I'm completely aware of. I know who I am, and I know I'm constantly getting to know myself. But I do like to think that we take some steps to make sure that the voices of the people most affected are heard. And I'll say I'm very much in the minority, on my teams. I'm, usually the only white woman there, but I'm still often the co-head or the head. And I recognize that that's really important. It makes a difference. And one of my, professional goals is to, mentor more and more researchers of color into these roles so that I can, step out.
Thank you. We have time for another question. The question is about your interest and experience with people with disabilities. Mm. Have you worked with people with disabilities, and do you see that your work maybe can be applied to people with disabilities?
Well, absolutely. I mean, discrimination against people with disabilities is, massive. And in fact, some of the most robust anti-stigma intervention work comes from the field of mental illness stigma. And there's really good evidence around community level sort of awareness raising campaigns and its impact and potential to lower community level mental illness stigma. And so that's one area where, you know, people may be living with a mental illness, they may be, you know, labeled as disabled, or they may self-label as disabled or not, but that work is already being done. In terms of other disabilities, it's really, you know, clear that there's, you know, tremendous stigma associated with cognitive disabilities and physical disabilities. And all of the mechanisms that we used in change can be used, you know, with any kind of form of discrimination, contact, education, perspective building to, you know, to build empathy, and the environment can be changed. I think the physical environment, the built environment, has to be addressed more effectively to reduce segregation of people living with physical disabilities. Segregation is a powerful tool for maintaining different sorts of systems of oppression, whether it's white supremacy or you know, keeping people with disabilities from fully participating in society. If you can't navigate your physical environment because the infrastructure has been so divested from that you literally physically can't get around, and New York City is a prime example of that. We don't have accessible subway stations. We don't have accessible public schools. These are massive human rights violations that prevent people from full engagement in everyday activities. So would I focus on contact or perspective taking for an anti-stigma intervention around that? No, I would focus on infrastructure. I would focus on making spaces physically accessible, you know, but you can use all of those other mechanisms for any form of discrimination. But the question is, should you, I think, is that where you should focus your energy?
Thank you. I want to take another question, and I promise this is the last question, but it is an important one. The question is about thinking of your work on IPV and on PrEP. How is IPV both serve as a barrier and motivator to seek PrEP for MSM?
Oh, that's a great question.
Yeah, that's why I didn't want to leave without asking these questions. So
yeah. We do among women experiencing violence may increase interest in PrEP. This is a preliminary finding coming out of the Just For Us study led by Anne Titleman at Penn. And she's working with Hong Venture at the New York Blood Center and Beryl Koblin, formerly of the New York Blood Center. And for gay men, certainly one would imagine that that association exists there too. We looked at that in our trust data, and we actually didn't find an association, but we had a pretty small sample. A really talented student, Marcus Mosley, actually just looked at that recently. Just last week, we were looking at his runs. However, it's absolutely, it makes perfect sense that if you're experiencing relationship violence, PrEP would probably be a good option. You're likely less able to navigate reducing risk. Cabotegravir, now we have injectable PrEP, pretty invisible, a good option for anybody in that kind of relationship that's violent or coercive. But that really highlights that we need to focus on that more.
Yeah, thank you very much, Dr. Frye, for an outstanding presentation and for your great work. We appreciate it. I know we have 2 minutes. We need to turn to the Dean for a final words, and thank you. And we appreciate the time you took to speak to us.
Thank you so much. It was my pleasure.
Well said, Nabila, and sincere thanks to both of you for a really comprehensive and stimulating conversation. Nabila, excellent moderating as always, and Victoria, thank you for sharing your community-centered, community-driven, and community-engaged collaborative work. There have been some great comments in the Q&A that you probably haven't been able to see, that calling your work outstanding, incredible, and inspiring, and I know we all agree with that. It clearly centers and contributes to broader efforts to disrupt and dismantle systems of oppression. So thank you for all that you do and for a great talk.
Thank you.
All right, and thanks and best wishes to everyone who's joined us. Glad you were here.